Okay. So do we have enough people in the room? Can I start? Okay. Okay, great. Hello, everyone. Good afternoon, good evening, wherever you are. My name is Paulina Tendana. I'm a senior lecturer at the University of Ghana School of Public Health and have also been involved with some of the discussions and empirical work that the H3 Africa Ethics and Community Engagement Working Group has been doing over the last 7 years. And I'm really delighted and really thank the organizers for the opportunity to co-chair this session on community engagement and the ELSI issues that we have been discussing over the years. I'm also delighted to be co-chairing with Professor Himmler, and I really look forward to us engaging each of you on these very interesting topics. We have 4 presenters today, and our first presenter is Dr. Cynthia Muno. She is a postdoctoral fellow in bioethics at the Division of Human Genetics, University of Cape Town, South Africa. She's interested in questions of equity, fairness, and governance of genomics, emerging biotechnologies, and infectious disease control. Cynthia combines both normative and empirical bioethics methods to explore and analyze ethical, legal, and social issues in biomedical research. And I think we are so privileged to have Cynthia to present on community engagement in genomics. Over to you, Cynthia.
Thank you, Chairperson. Good afternoon to everyone attending this session. It is a pleasure to be able to give a presentation at this 13th meeting of the African Society of Human Genetics. I would like to thank the local organizing committee, that is Dr. Siana Nkia and her team at the Tanzania Society of Human Genetics, for inviting me. My name is Changwi Cynthia, and I will be presenting on equity-oriented governance of genetics research in Africa. If genetics or genomics is to deliver on its promise of precision medicine, then the outcome of genetics research would have to be transformed into tangible clinical interventions, such as diagnostics, health services, analytical tools, amongst others. But for this to happen, it will need the concerted efforts of a wide range of stakeholder groups, including but not limited to research participants, researchers, healthcare workers, national governments, and commercial companies that will be able to support the development of new interventions or products. While there is acknowledgement and there is optimism of the promise of genomics to improve healthcare, there are parallel concerns that if care is not taken, genomics may widen health inequities, both globally and across socioeconomic strata within countries. These concerns are were based on observations around the limited inclusion of African populations in genetics research, differences in research and development capacity, including support for innovation between high-income countries and low and middle-income countries. There are also concerns around the missing African voice in the global genomics discourse and how these may impact genetics research priorities globally, and by extension, translation of genetics research such that we may end up not having sufficient genetic studies that are addressing the health needs or the disease burden in sub-Saharan Africa. There were also parallel concerns around inequitable global health research collaborations. And this was a major concern amongst genetic researchers in Africa. A significant progress has been made in addressing some of these concerns, especially the inclusion of African patients in genetics research and developing capacity for genetics research. Much progress has been made, especially with initiatives such as the H3 Africa. But at the beginning, these concerns were really pressing, leading the ethics working group of the H3 Africa Consortium to sort of develop a framework for the governance of genomics research in Africa. This framework touches on key ethical issues around broad consent, community engagement, equitable international research collaborations, and the importance of African intellectual leadership of genomics research that is ongoing on the continent. The framework was inspired by communal or solidarity-based worldviews that are predominant in sub-Saharan Africa. And therefore it is grounded in principles of solidarity, reciprocity, and consultation. An African ethic of interest at the time that this framework was being developed was Ubuntu, and many thought at the time that we needed an African philosophical worldview that we could use to analyze ethical issues in genetics research in Africa, as well as global health research more broadly. And so Ubuntu was the ethic of choice at the time. And we would all know that Ubuntu is an African communitarian ethic that is centered on solidarity. We've since done a conceptual analysis of the African worldview of Ubuntu to be able to identify principles that may be used to analyze the different ethical issues that I talked about at the beginning. And the conceptual analysis yielded quite a number of principles, including solidarity, reciprocity, shared decision-making, inclusivity, and open sharing. To be able to get an understanding of how the principles we identified from Ubuntu could inform the governance of global health research or genetics research in particular, we compared Ubuntu to two theories of global health justice. The figure on this slide presents some of the principles that we identified, including what they will mean for equity-oriented governance of genetics research in Africa. In this presentation, I will focus on three of these principles because they are of direct relevance to the theme of this conference, which is genomics and translational research to improve health care in Africa. The first principle I would like to talk about is shared responsibility. And a key question to us all as African researchers or African genetics researchers is that what are our equity-oriented responsibilities towards ensuring that genetics research in Africa or genetics research globally does not widen health inequities, be it globally or in our different countries. And I think that quite some discussion has gone into the identifying or discussing the equity-oriented responsibilities of different stakeholder groups. But we haven't really talked much about the equity-oriented responsibilities of African researchers or African genetics researchers. And I think it is important to reflect on this and to ask ourselves, what are our different, or what are our equity-oriented goals and outcomes in relation to our different projects? That is, how are the projects we are involved in actually addressing concerns of genomics and global health inequities? Two ways to think about this is to, first of all, ask ourselves the question, in our different projects, do we have defined equity-oriented goals and outcomes? Secondly, do all stakeholders in these projects have a common understanding of what these equity-oriented goals and outcomes are? If we are not able to answer these questions, then it becomes difficult to state clearly what we consider to be our equity-oriented goals as African researchers. When we did the conceptual analysis of Ubuntu and the two theories of global health justice, we identified three main equity-oriented responsibilities of African genetics researchers. The first is around furthering the ideals of health justice, both globally, at the level of the African continent, and at the national level, that is, at the level of our different countries. So, what is our responsibility towards ensuring that genetics research is translated to advance healthcare for everyone? The second equity-oriented responsibility relates to decision making. And the third equity-oriented responsibility is about the equitable use and distribution of resources, such as genomics data, expertise and infrastructure for genetics across Africa, and benefit sharing. That is how our different projects respond to issues of access to new interventions or to genetic medicine services by study populations. So the first equity-oriented responsibility, which is around furthering the ideals of health justice, it lies more in the translation of genomics research to health benefits for study populations, especially worse-off populations. And there we are sort of tasked to identify what are these worse-off populations, and they may differ based on national demographics or on the disease on the study. And to sort of identify or to sort of start discussing how genomics could impact, or genomics research in Africa could impact on global health and global health inequities. We did a qualitative study where we asked African researchers about their perceptions on how genetics research in Africa could impact on global health and address global health inequities. The study identified priorities for genomics research in Africa from the perspective of African researchers. And the results can be grouped broadly into four main priorities. The first is around identifying priorities for genetics research and genomics at the level of the continent and at the level of the different countries. And what factors will sort of inform genetics research priorities? Would that be the disease burden, or would that be the cost-benefit ratio? So for particular diseases, will the priorities be different? So in that study, many African researchers were of the opinion that we should be able to identify what the priorities are, both for the disease burden in Africa as well as for specific diseases. The second priority was around human and infrastructural capacity for genetics. And there's been some advances in that area, noticeable advances in genetics research capacity in Africa. But one thing to consider is also the distribution of this capacity across the continent. So is it equitably distributed, or do we feel like it is concentrated in specific regions or in specific countries, such that there are other countries that have little or no capacity for genetics research or for genetics medicine? It is also important to sort of look at the distribution of the capacity at the national level, especially the capacity for genetics medicine. So where is it located? And are all population groups within the same country able to access genetic medicine services? The third priority area was about knowledge generation and translation. And the results of that study showed that it was important to be able to look at how we could integrate ongoing research capacity or ongoing genetics research to support genetic medicine services or their development in African countries. So how can ongoing genetic research in our different African countries be able to kickstart genetic medicine services where they do not exist? And where they exist, how can they support those services? Another area of concern was about trained personnel in terms of medical geneticists and genetic counselors. There was also the need to define or to develop regulation and policies that will support the implementation of genetics medicine in Africa. The last priority area based on that study was awareness on the role of genetics in health and healthcare. And this was about thinking about how we engage the public. So what is it the public already know about genetics and health? And what is it, and where is the gap? And how can we as researchers fill that gap? At the moment, there is very little public engagement in genomics in Africa, and there are little or no models on how to effectively engage the public in debates or discussions around genetics and genomics medicine. There was also another area where the researchers thought that there was need for improvement and it should be prioritized, is awareness of genetics amongst healthcare workers. And so a previous study had shown that many healthcare workers had limited knowledge of genetics. So that's the study we did actually highlighted that area as a priority for genetics research in Africa. And there's some ongoing work around that to improve knowledge of genetics amongst healthcare workers in Africa. The second equity-oriented responsibility I would like to talk about is shared resources. And this relates to the use of resources such as genetics data and it is to reflect on our data sharing attitude and practices in Africa. How open are we as African researchers to sharing data, both with our colleagues in Africa and out of Africa? A second important resource that is key to how genomics may impact global health and global health equity is intellectual property models or intellectual property. And the priority there is to be able to identify models, IP, intellectual property models that would encourage innovation, but would not serve as barriers towards improving access to genomics innovation by people in Africa. And the third resource that we need to reflect on is genetic services. And that is how easily accessible are genetic medicine services to populations in Africa, and how are our different projects sort of ensuring that populations in Africa will, in the future, be able to easily access genetic medicine services. The final equity-oriented responsibility of African researchers that I would like to highlight is shared decision-making. And there are different stakeholders that should be involved in decision-making in genetics research in Africa. But for this presentation, I would like to highlight one particular stakeholder group, which are the resource providers. By these, I mean the study participants or the patients or our study communities. And the question is, how are we engaging them in decision making? At the level of sickle in Africa, we've learned quite a lot around the engagement of patients in genomics, in the governance of research. Sorry about that. Sorry about that. And so we've learned a lot about how to engage patients in the governance of research, where we've adopted a model of patients as partners. And what we've learned quite a lot from them, including that they would like to be meaningfully engaged across the research pathway, not only for specific activities. So one area where they were keen to participate was in determining research priorities. So for example, we had patients actually asking why gene therapy, why there are no ongoing studies on gene therapy for sickle cell disease, and that they would love to see that kind of research ongoing in Africa, particularly because they had read of successful cases of gene therapy for sickle cell disease in other parts of the world. We've also sort of learned from them that they would love to be involved in decision making around the use of data and to be able to inform public engagement models and to be involved in the design of public engagement activities at the very early stages. So in summary, it is important that as African researchers, we define our equity-oriented responsibilities for each genetics project that we are involved in, including how we are working towards furthering the ideals of health justice, both globally and across the different socioeconomic groups in our different countries. This is the end of my presentation, and I would like to really appreciate the African Society of Human Genetics, my colleagues at the Sickle in Africa Data Coordinating Center, and the GeneMap Research Group. I would also like to acknowledge the patient support group leaders in the Sickle in Africa Consortium, as my interaction with them has helped shape some of the discussions in this presentation. I thank you for listening.
Can you hear me now? Okay, great. All right. Great. So thank you very much. Am I on? Okay, all right. So thank you very much, Dr. Cynthia Monon, for that very excellent presentation. You've raised quite a number of issues for us to reflect on, and I think we have a few minutes, about 3 minutes, for a quick Q&A before we go on to our next presentation. I'm just looking at the any questions for Cynthia? I'm still getting used to the tech here. Okay. So I think this is more of a comment. Oh, sorry, yeah, it's difficult to see. In the live chat, yes. Michelle Ramsey. Okay, great, great. So thanks, Michelle. So Michelle says, Cynthia, thank you for a thoughtful presentation. How do we balance awareness of genomic medicine with the fact that we cannot provide services in most African countries? And then I think a follow-up is, how do we manage expectations and not lose the excitement of what is becoming possible in the global north? So two quick questions here for you to respond.
Yes, thank you, Michelle, for that, for the questions. I think in terms of balancing awareness of genomics medicine and the fact that these services are relatively not available across Africa, it's to be transparent about what is available and what is there in our different countries, and to be able to tell participants that these services may be available only in some tertiary institutions, or they are not there at all, but that we hope that with advances in genetics medicine, or with advances in genetics going interactions with government, these services may be available in the future. In terms of how do we manage expectations and not lose the excitement, I think it's only about transparency. It's about honesty, being able to say that this is what can be done, this is what is possible, these are the services that are available at the moment. We can only sort of engage government and policymakers to make these services available. So it's all about honesty, as being clear on what is possible at this time and what is not possible.
Great. Thank you very much, Cynthia, for the response. We have another question from Colette Dandara. And so he also says, Cynthia, thank you so much for your presentation. Do you have any examples in community engagement where processes taken by genomic researchers were informed by what the community wants rather than what the researchers thought was best for the community? Very good question there is.
Yes, I think from the sickle in Africa experience, we sort of had what we thought the patients would want, but the patients already had something in mind, and perhaps in that case, it's because this is sorry. Uh, Perhaps this is because it is an organized patient group. So by themselves, they've had so much thought about what is it they as a patient group want. And so they've been able to sort of change our agenda quite much. And we've been open to listening to them and changing the way we engage with them more. But I think that happens when there is an organized group more than there's no structure in place, and so it was a bit easier for sickle in Africa compared to other projects.
Okay, thank you very much, Cynthia. And then just to chip in to say that I think from my experience from the Our Agent project, when you work with, if the staff of the project are also part of the community, they are able to bring in that expectation and in terms of their experiences, because they are staying with the communities and then they hear a lot of the feedback. So if we're able to include more locals on the research team, then we are able to make sure that we tailor the community engagement process to reflect what the community wants rather than the top-down approach that is often used. So thank you very much. I think that's all the questions that we have. So let me use the opportunity to thank you very much, Cynthia, for the excellent presentation. I hope you would publish what the paper that you've just presented. And so I wish you well. And I hope to engage with you more in the near future. Great. So I'll hand over now. Okay, do we have? Okay. So I'll hand over now to Professor Himla to take us through the rest of the presentations. Himla?
Well, good afternoon, colleagues, from wherever you are joining us this afternoon. It has really been an awesome display of science on the African continent thus far. I have managed to catch a couple of sessions in between my day job, and I must say it's been quite an inspiration, having been there at the beginning of the genesis of the H3 Africa program before it was launched, and for it now being live for almost 9 years on the African continent. And as we've heard from the first speaker, Cynthia, the space of ethics and attention to the way in which we as researchers engage with the communities that we serve with respect to the science that we wish to do is such an important component to this agenda. Cynthia has kicked us off in a very nice way by sharing with us the broad strokes of the issues that we should be cognizant of on the African continent. And that's kind of given us that space from which to launch. I believe our organizers are trying to load the next presentation. And as soon as I get the go-ahead from them, we'll be able to invite our next speaker, Maureen Manyama, to speak. Maureen is quite an exceptional advocate for science because she is, in fact, a patient advocate and a founding member of Lupus of Warriors in Tanzania, which is a non-profit organization that is dedicated to generating visibility and public understanding about lupus and its impacts on those living with it. Her work in patient advocacy is actually inspired by her own personal battles within the healthcare system following her diagnosis with lupus. She has presented at numerous fora, at local and international conferences, and I'm sure that she's going to bring into focus why we need advocacy for patient centered care. Colleagues, are we ready to roll with Maureen's presentation? This is a very sophisticated system. It reminds me of Star Trek, you know, beam me up, Scotty. You get invited to one window and then you get beefed up into another one. So it is quite engaging with all of that. So I'm just still waiting for the organizers to load Maureen's presentation for us. And perhaps in the meantime, we could think about what Cynthia has spoken to us about in terms of the kind of agendas that we currently see, excuse me, on the African continent, particularly that interface of science, and in this instance, genomic science, at various levels of advocacy. So there we go. Are we ready to go? Wonderful. So, ladies and gentlemen, let's welcome Maureen into the room and allow us to share with us her experience from Lupus Warriors Tanzania. Over to you.
My name is Maureen Manyama. I am a patient advocate and a founding member of Lupus Warriors Tanzania. I have been living with lupus for 5 years and now describe it as being in a state of an internal war with your own body. Lupus is a chronic autoimmune condition where your immune system attacks itself. The attacks can be on any organ in the body. There's no cure, it's debilitating, and if it's left untreated, it can be life-threatening. Public knowledge about lupus is very low, and it's still a mystery. We don't know the exact cause, and it's described as an invisible illness. Unless the skin has been affected, it's hard for others to see and understand it. Quite often, patients like myself don't necessarily look ill. People would say to me, "You don't look sick," but they don't realize that it's painful, both physically and mentally, living with this condition. One of the biggest challenges of lupus is getting the diagnosis. Since the attacks can be on any part of the body, it makes it difficult to diagnose. On top of that, its most common symptoms mimics those of other illnesses. For example, if you're presenting with a fever, chest pain, and mouth sores, you'd be put on treatments for malaria or tuberculosis over and over, even with negative lab results, because they don't know what's wrong with you. And every case of lupus presents itself differently. One could have kidney involvement, another does not. So it can look a bit different for everyone. Some of my fellow patients I know have had to wait 3 to 6 years before getting a proper diagnosis. In Tanzania and Africa in general, the belief or assumption is that the prevalence of lupus is very low. I challenge this because studies have shown that women, and particularly people of color, are more likely to develop this condition. We face unique challenges that result in the lack of a diagnosis, misdiagnosis, and underdiagnosis. We also lack data. There are no solid statistics that can give a true idea of the prevalence of this condition on the continent. Some of these challenges include poor access to healthcare, low disease recognition related to low awareness of lupus at primary healthcare settings. There have been many occasions where some of us have gone to local hospitals and physicians do not know what lupus is and would have to explain it to them and inquire if they are able to give us the proper treatment. So the need for increased awareness is not just for the public, it's also needed amongst healthcare workers at all levels so that they can be sensitized to pick it up early and refer to specialists early. Also, there are inadequate number of specialist physicians. Tanzania has a population of about 58 million people, but we only have 2 rheumatologists. This is inadequate and it needs to change. People with lupus can attend other clinics with other specialists such as nephrologists and dermatologists. But even so, the number of these specialists that can treat lupus is low. Also, the diagnostic tests are often not affordable, and until recently, samples have had to be sent to South Africa, Europe, or anywhere else outside the country for people to get their results. It's been good fortune that as of late, our hospitals have been able to do this diagnostic test here. When it comes to treatment, it's limited by its availability and cost. It's expensive. My own treatment can cost me up to 2 million Tanzanian shillings a month. This is not affordable for a majority of individuals, and the result is that some are not consistent with their treatment plans, and that can cause more damage and potentially loss of life. Due to all these challenges, we came together to form Lupus Warriors Tanzania. There was a dire need to advocate for the needs of lupus patients in the country, and we do this in the following ways. First, people with lupus are prescribed specific drugs and tests that are not supported by health insurances. In turn, it requires high cash expenditure out of their own pockets. Through this organization, we hope to be a mouthpiece for patients to secure essential drugs affordably through the National Health Insurance Fund. Most recently, we organized a petition to the government to include hydroxychloroquine on NHIS. At the beginning of the...
Okay, let's go do this quick.
Yeah. At the beginning. Pole. At the beginning. Is it so seen? Nani kwa kwenye kemi? Just At the beginning of the COVID-19 pandemic, there was an increase in the demand for hydroxychloroquine, which led to a shortage and tripling of its prices, and therefore making it difficult for lupus patients and others to acquire it. The Ministry of Health responded to the petition, and hydroxychloroquine is now included in the standard treatment guidelines and National Essential Medicines list for Tanzania. This is a win for every person with a condition that needs to be treated with hydroxychloroquine. Secondly, being a fairly unknown disease by most Tanzanians, we raise awareness on how it manifests itself. The help and support networks are available so that it can help many people seek and get the needed help early. This will hopefully change the inclination to seek help from traditional healers, as most think of being bewitched when they do not understand the disease. Thirdly, lupus patients, especially those whose skin gets affected or have what is termed as cutaneous lupus, are often stigmatized because of how they look and because of the lack of understanding by the community of the disease. Hence, education and awareness will hopefully change the community's attitude towards lupus patients. Lastly, it's about having a platform where people with lupus and their caregivers can come together and share experiences. It fosters strength, emotional welfare, and support. Our hope is that the organization provides a platform at which lupus patients will feel happy to come home to. All in all, for improved health in Africa, we shouldn't forget about those affected by rare diseases. There needs to be combined clinical and research efforts towards improving outcomes for African lupus patients and those of other rare diseases. We must talk about it. We must get the government involved, and for it to say that this has to get just as much attention as other devastating and potentially fatal diseases. We need more research, and we need more physicians, specialists, and scientists thinking about rare diseases and working in this area. And this needs to happen now.
Greetings, everyone. I would first like to express my sincere gratitude for giving me your precious time, your ears, and attention in this very important conference. My association with this conference is just because I am part of the subject, a mother of 2 victims. I therefore thank you so much for this opportunity. For us parents and patients of rare disease, this conference is not just another gathering. It presents to us something more valuable, a hope. The coming together of a great mind like yours will raising the agenda of rare disease to its deserved attention. We are optimistic that joining together our voices will be heard and attended. My name is Sharifa Muhammad Mbarak, a mother to two rare disease affected children, Nasreen and Ali. Nasreen is no more. She gave up early in fighting this hard battle and passed away at the age of 3 in 2016. Ali, who has survived to 10 years so far, has been through untold hardship that many of us have never seen. Both Ali and Nasreen have been victims of double-edged tragedy. First, nature has picked them among those few to live with rare disease, and second, they are victims of geography for being born in a country where knowledge, understanding, and appreciation of their plight is very little. The story of our children is not unique to them. It's the story of many other children in Tanzania living with rare disease and family that takes care of them. Lack of diagnosis. We've not been successful to get right diagnosis of early so far. Also, one experience is common across developing countries. There's little appreciation about rare disease, and data are not adequately available. As a result, rare disease receive no or limited mention in health policies, and if acknowledged, little is done to translate into specific services and interventions in health system and supportive system like health insurance and education. Being the mother of two rare disease children in the past 10 years, I have observed the following. Healthcare and social support services that exist are designed for patients with common disease, with little or no regard to needs of patients with rare disease. Lack of diagnosis results in patients and families being denied necessary services in hospitals, schools, and the community, and lack of family counseling and assistance programs on a short-term basis to help families coping with a rare disease. That's not all. For most people living with a rare disease, as well as their family members or caregivers, the reality of daily life includes any combination of the following: collecting and taking medicines, attending appointments, participating in physical therapy, using special equipment, and accessing various social and community support services and respite care. In absence of dedicated health support and rare disease children, parents and guardians become paramedic by default. Those altogether sum up to a full-time unpaid job. For some of us with a career life, the honors can be unbearable. As apart from working with the government, I've dedicated my efforts in founding Ali Kimara Rare Disease Foundation, which was established in 2016, and I am the chairperson of the foundation. The vision of the foundation is to become the voice for rare disease affected children in Tanzania. In order to reach our mission, we aim to achieve the following goals: increasing visibility of rare disease in Tanzania and at global level, fighting stigma and get rid of the taboo within families of rare disease children, extending and share knowledge about rare disease and their unmet needs, promoting international multi-stakeholder collaboration and action for rare disease, and aligning rare disease as a global priority in public health, research, and medical and social care policies. We know so far there are no treatment for rare disease. We believe, however, that is not a reason good enough to condemn rare disease patients to fate. The least we should do is to assure them dignity, care, and support. Yes, we cannot cure, but we should at least be able to help patients to overcome related complications. This can be met if we assure patients access and affordability of tailored health services. This, I believe, our government is ready to do it, as how we all witnessed in 2020 and 2021 during Rare Disease Day commemorations with the president of the when the president of the Tanzania, Honorable Samia Suluhu Hassan, by then she was the Vice President of Tanzania, promised to act on this agenda and also to be the voice of the voiceless. The commemoration was jointly prepared by Ali Kimara Rare Disease Foundation and Tanzania Society for Human Genetics and brought together the cross-section of participants from victims and families of rare disease, political leadership, policymakers, from health and education fraternity, practitioners, religious leaders, private hospitals, and insurance companies. Well, from that commemoration, both governments committed their readiness to work on the recommendation aired by the Children with Rare Disease, caretakers and professionals, to see a possibility to establish a coordination unit within the Ministry of Health for Rare Disease, to consider undertake a census and to establish a register of children with rare disease to start with, to explore the best ways to ensure access and affordability to healthcare for children with rare disease, including possibility to waive costs and a provision of health insurance, to support and encourage research in human genetics in Tanzania and rare disease in specific, work with Ali Kimara Rare Disease Foundation and Tanzania Society of Human Genetics to promote public education and knowledge about rare disease. Policy and the laws should be established or reviewed in order to ensure that children or people living with rare disease are provided with their constitutional rights and important services, including the right to education in a conducive environment by taking into consideration of their condition. And I would love to say that now the government or through Ministry of Education is recognizing these children and they recognize homeschooling system. Ali Kimara is the first child to be registered to get his education at home, and now they are reviewing the guidelines and policies of education to include these children. It's a good thing. Well, from that, I've decided to rise the challenge and become a voice and a champion for kids with rare disease. I decided to see the responsibility to advocate for their right to education, medical treatment, care, attention, and equal opportunity within the country. I thought and I believe my own experience and healing journey is rare and may help to educate others to overcome the trauma and huge stigma surrounding the kids with rare disease. I want to tell the world that we, the parents and caregivers, do really value our children. We hold a belief that children with rare disease are special and need equal rights, love, support, recognition, and education like other children. And it's time to take action for people living with rare disease to have equal opportunities to realize their potential because it's possible, it's doable, it is achievable. My dears, I would love to tell you all that rare is not rare as you think. In fact, rare is not scarce, rare is not infrequent, rare is not remote. Rare is precious, rare is many, rare is strong, and rare is proud. I believe Ali Kimara Rare Disease Foundation and Tanzania Society of Human Genetics will keep on working together to reframe what it means to be rare. Last but not least, we appreciate so much and thank you all for listening.
Hello, my name is Arafa Salim Said. I am the president of Sickle Cell Disease Patients Community of Tanzania. The Sickle Cell Patients Community of Tanzania is a non-governmental organization set to provide education and awareness on sickle cell disease in Tanzania. The organization supports groups of patients within the community through conducting both public and social media campaigns on sickle cell disease, sponsoring children's health insurance, and hosting events and workshops providing training, education, and information materials on sickle cell disease, such as books, articles, and keeping the sickle cell community members updated on current medical research. As a warrior living with sickle cell and a patient lead in Tanzania, our cry is, first, access to sickle cell clinics is challenging, especially for those residing in rural and in outskirting areas. Due to this, many patients are forced not to attend clinics as requested, and many have to travel a long distance to get the care they need. Secondly, healthcare workers sometimes have limited knowledge of sickle cell disease and in some instances downplay the pain that is reported by a person experiencing a crisis. Some cases may be requiring hospitalization for close consultation but are treated as OPDs. Thirdly, no access to health insurance, so are not being able to cover costs due to the factors such as income, unemployment, and low living conditions that binds most patients from having access to healthcare insurance packages. These are forced to pay cash for services, which is expensive and a burden to patients and family. Fourthly, many warriors had challenges accessing the sickle cell clinic during COVID-19. Fifth, we need to have centers for diagnostics. Diagnostics for sickle cell is very challenging. So we hope to have centers for diagnostics for sickle cell. Six, we would like research centers to work hand in hand with the sickle cell disease community of Tanzania and advocates, but also to not be clustered in one area. 6, we would like research centers to work hand in hand with the sickle cell disease community of Tanzania and advocate, but also to not be clustered in one area only, but to be equally distributed throughout across the country. No, I think I should look at the camera while saying that. Yeah? Okay? Okay? 6, we would like research centers to work hand in hand with the sickle cell disease community of Tanzania and advocate, but also to not be clustered in one area only, but to be equally distributed throughout the country. 7th, we need transparency, information. 7th, we need transparency, information guidelines, and data openness. When working with researchers, data should be shared openly and transparently. 8th, we need funds to NGOs and advocates so as to enable and equip us to fully be there and cooperate with the researchers. Okay? 8th, we need funds to NGOs and advocates so as to enable. 8th, we need, okay. 8th, we need funds to NGOs and advocates so as to enable and equip us to fully be there and cooperate with these researchers. In general, many warriors would like fair access to health and social services, such as jobs, education, and hope that organizations like the WHO and UNESCO would recognize the challenges people living with sickle cell face and invest in researches, healthcare, and sickle cell disease, as well as give sickle cell disease warriors a voice when they develop policies for sickle cell disease. Thank you.
Thank you very much to those three presenters for reaching out the problems that you are subjected to on a day-to-day basis in terms of your own experience with rare disease, your experiences as a parent, a family member supporting a child with rare disease, and then just the general experiences around the way in which one needs to engage with society on the one hand and policymakers on the other. I think you have raised with us important considerations here. The first is advocacy and the role that various partners in the advocacy pipeline need to be noticed and what it is one needs to do to become noticed. Sarifa shared with us her commitment for writing a paper and starting an organization for what her kids have gone through. Maureen has spoken to us about her level of advocacy in terms of bringing lupus into focus, both educating not just the public, but also healthcare people. And we have been told in the last presentation the challenges we have with respect to bringing the knowledge to the people concerned. So yes, I mean, your stories have been incredible. So let's see what we have in terms of questions, of any, if you would like to add anything more to the conversation while we are in this live chat. Let me quickly check if we have any questions from people in the session. So I mean, one of the things I would like to pose to each of you is, to what extent have you enjoyed the likes of co-creation of your science with researchers on the continent? Has that experience been useful? Namely that if there are scientists wanting to work on this particular disease, have they discussed with you or engaged with you, or how has that experience been? Anyone?
I can. Hi, my name is Arafa again, and I can speak about the experience that we have with Sparkle Tanzania. Uh, we do research. They do research, but we are very connected. Like patients are all engaged. As a patient leader, I am engaged and make sure that every patient who is eligible to be in the research should be included. And the important part is with the research is where we get you get to be in the data, and that, as we all know, that data collection is the most important part now. So that's my side, my story. Can hear from Maureen.
Maureen?
Hello. Hi, my name is Maureen. Thank you for the opportunity. On our side, the lupus community, we're yet to meet a researcher or anyone in that field who's currently working on solving this mystery that's lupus. We're yet to meet any researchers on the continent. However, we have seen and heard about research happening in different continents like Europe or in America, but we tried to reach out. They're saying that it's only for their population. So on our side, that is yet to happen, and we are hopeful that in the future someone will be interested enough to work in this area with us.
Yes.
Hi. Thank you. My name is Shamiko. Thank you. Thanks for everything. Thank you for listening to us. Well, our story is a bit different because till to date, we've never got a diagnostic for early, even for the deceased sister, apart from trying everywhere around the world for the tests and everything, exome sequencing, different tests, but most of the researchers kept on guessing maybe it should be muscular dystrophy, or maybe it's this disease or this type of muscle disease, but still couldn't manage. So we're still searching.
Yeah,
Yeah,
yeah.
unknown.
I know that you all have very punchy messages in all of your presentations, but now you have the platform to be present on one of the premier meetings of bringing together the researchers on the African continent in partnership with the H3 Africa network of scholars. What is the one message you would want to reach out either at government or at researchers or whichever level, to use this platform to put your message out there for a plea to support and engage the activities you're involved with? Let's do it in the reverse order. Let's start with Safira first.
You want to start?
Well, I think Africa should join together right now. We need diagnosis center for African country, for African continent, because most of rare disease are based on other countries like Western countries. Most of the numbers, we do not have a register for African countries. It's about time now. It's about time to start our own genetic tests and everything. I think that is possible if we all join together and support this movement and have a one database registry for African countries, and at least we know like which type of disease, which type of which group this child belongs to, where the child is, which age, and other complications. At least we would know how to start, you know. And we all know getting a disease or diagnostic is 50% of cure. Even though we cannot cure rare disease, but at least we can support the child whenever they get other complicated diseases. Yeah. So it's very
Excellent.
important. Thank you.
All right, next.
I support Sharifa's message in such that in Africa, I think the assumption or belief is that the prevalence of rare diseases is very low. But in actuality, it's that people are going undiagnosed or they're misdiagnosed. And we have several different challenges that I think we've all highlighted in our individual videos. So I think I support Sharifa that if we could have just as much attention to rare diseases as other devastating diseases, we'd realize that, hey, the problem is much bigger than we think. And also, I would also like to say that we need more specialists. So for example, in Tanzania, the population is about 58 million people, but rheumatologists, there are only 2 rheumatologists in the entire country. Just see that in the population. So it's really challenging. And I think that's an area that we can also improve on. We lack specialists, for example, for lupus. Lupus can see nephrologists and dermatologists, but even the ones that we have, not all of them can treat lupus. So people would have to travel long distances just to come to the capital city to get treatment. So I think having a diagnostic center and just more specialists, those are the areas that we could focus on.
Thank you. Rafa?
Oh, thank you so much. I think you guys have taken all my words. First, it's very true what Sharifa and Maureen is saying. We are most of the time people are misdiagnosed with what they have, and that is a problem. And also getting to be diagnosed, because you need to travel very long distance to come to the city to be diagnosed. It's Africa. We don't have that. We're not big. We don't have a lot of money. Our families are not rich, are not. They need a lot of support. So, if we can manage to get a diagnosis center in different places, not only the city, but also have professionals. We need to have professional doctors, hematologists, so that whenever you see a patient, you diagnose straight, and you get your results on time, so that if the interventions is and everything goes.
Yeah,
We
there's
do
there's
need
a
diagnosis.
Yeah, thank you. There's a question in the chat by Sigan Fatumo, who says, as patients and parents, how comfortable are you when researchers request to use your anonymous data and share with other researchers globally? So are you happy to share your data or that of your child's with other researchers on the international sphere, provided it is anonymized?
It's definitely okay if it's going to bring a results. And as I said in my talk, that we need transparency. Like when you come to us, you need to be transparent. I'm doing this. I need your data for 1, 2, 3, 4. Even when you're doing the talk or you're doing a research, I should be involved. I should know what is going on, but not just come here, take data, go get maybe your PhD, get whatever.
Yeah, that is what I meant by the concept of co-creation, that the researchers sit with you and you discuss together. Yeah, you discuss together what it is you'd like to do, set the rules of engagement and those sorts of issues. Because, I mean, having worked at, the front line of research for over 3 decades, it is always been observed that when people want a sample, they go into an area, collect it, and that's the end for most people's journey to collect a sample. So what you're saying is absolutely right, that you're willing to participate, provided at the very beginning you set the rules of engagement and both parties are completely transparent in the agendas that they wish to take forward. I am not sure if we have the last speaker. Is Clarissa available? Because this is an interesting discussion and I'm sure the colleagues would be happy to continue. Oh, we still have time. Yeah. Colleagues, the other question that I would have liked to ask is, to what extent has the impact of the COVID pandemic intersected with the issues that you would have wanted to follow?
That again, please.
I said, with respect to everything going on in your individual spheres of operation, to what extent has the COVID pandemic kind of made your operations difficult, if at all?
Helps to relieve some of the symptoms. No, what that did, hydroxychloroquine is an essential drug.
Okay.
Was a shortage. Of prices.
Right.
And we go to it will be triple the prices. I remember during that time we had to transfer medication from Dar es Salaam to Zanzibar and of Tanzania. People who are in rural areas could not access that medication.
Right, right. And
now,
with respect
to address that altogether, hydroxychloroquine is included in national health.
And testing and screening for rare disease. I mean, I really like the message that you put out, particularly in Sarifa's view, when she said that when you take it all together as a collective, rare diseases is not that rare. An individual disease may be rare, but if you aggregate the various rare diseases together, it makes up a considerable amount that is represented in the total population. And this is a soundbite that is rarely taken forward when we try to engage with the government officials, because they mainly go after what you have called the common diseases. But when it comes to the rare diseases, and as some have mentioned, that the cost for treatment of rare diseases, because it's one of the outliers, put huge demands on family and priorities within a family. So how would you see us addressing those issues towards making a better case for rare diseases within the healthcare system?
Well, as we say, it's rare might be rare, but it's not as rare as what people think, because we might be rare, but we are many collectively. Yeah, for instance, maybe if we had registry in our country, we would have maybe 5,000 people with rare disease, right?
The registry.
Yeah, the registry will tell everything.
Yeah, and who do you think should be responsible for doing such a registry? I mean, I know in South Africa, our Department of Health at one stage kept a database. And if I remember correctly, we have statistics somewhere around like 1 in every 11 live births is linked with some form of a congenital birth defect. And so this is data that we capture at the Department of Health level. But as has been mentioned, it's one thing making a diagnosis, but patients with rare diseases have so many other needs, physical disabilities, sight, and several other confounding problems. So the burden on the healthcare system is quite complicated and complex when you unpack the impact of the needs for support for the collective of rare diseases, and very little attention is paid to that. I am very pleased to see that you made a case for the constitutional rights of individuals with rare diseases and the right to education. I think that is a very important component in the dialogue as well, because if you have a medical problem with some form of a disability or other needs, why should you be ostracized within the bandwidth of the wider community? You deserve the same rights, if at all, some degree of compassion and human solidarity that we talk about when we talk about the collective of our humanity. So these are very important considerations, and I believe that every country's Department of Health needs to be made aware of the impact in terms of how it hurts the purse in the total economic arena, for them to realize what the value and impact of rare diseases really are. So would you like to comment on how we as a community of scientists could facilitate the lobbying of getting this advocacy to the right sectors? I mean, I know you do this on a day-to-day basis, but what is your wish list to see happen more?
Well, I think government should take the responsibility for rare disease.
They should help us.
They should
raise
help
our
us,
voice.
because the burden is real. It's huge. As
We are doing our best in what we can,
advocating, but
they can do
They
better
need-
with the policy making.
yes,
They need to listen to us and care.
yeah.
Right.
Government
Do you
should
know?
take full responsibility.
So today I'm wearing my cap in the chair as the executive officer for the Academy of Science of South Africa. So most African countries have academies of science, and academies of science is meant to be representative of that layer of academic excellence in the country that can also support and punt for initiatives for changing of policy or contributing to policy shifts in that country. So I would like to recommend to you, given that you are all mostly based in Tanzania, to look up the Tanzanian Academy of Science, get them in your camp, and look to the presidents and the executives within the academy to raise the bar, to raise that profile, because academies have the potential to have a little bit more of an access to government officials, and through them, through the network of academies on the African continent, as well, as well as to other instruments like the African Union, etc. So until we can join the dots of bringing together in a room, not just the scientists and the parents and support groups, but also other vehicles that can mobilize initiatives to raise the bar a little bit more, we should try. I mean, the more pressure and the more people who support these sorts of initiatives, the better. And I mean, I think having now just said that in a public forum, I need to also elevate the cause of the Rare Diseases Association in South Africa within our South African network of initiatives. Because at the end of the day, in terms of our constitutional rights, people with disabilities have a say. Every person has access to health in our system. But in our experience, the health system fails when we have a scorecard to see to what level have we ticked those areas where we have been productive and put a cross for where there's no response or very little activity. So I think that is another thing that I would like to share with you in promoting your advocacy efforts, to be able to bring in other voices into your campaign, to be heard or to be able to position what you want to do in growing the net, to have better outreach or better community engagement with respect to these rare diseases. So yeah, so I just wanted to share that with you at this point.
Thank you so much.
Yeah. No, and what about your networks in support across the continent? Is there some avenue for that? Are you, for example, in touch with the Rare Diseases Association in South Africa, or with the global network of agendas?
Actually, I am associated with South African Rare Disease Association, and they invited me last year, I guess, or 2 years ago, to attend the Rare Disease Conference, but unfortunately I couldn't attend.
No, that's such a pity, because Madame Duplessis is really, really active, the chairperson. When we were trying to resurrect the Southern African Inherited Diseases Association into the Genetic Alliance of South Africa, I was part and parcel of that working group, where we set out to, put out a statement in going forward. But at the end, I think that associations now become aligned with the rare diseases. It seems senseless to have multiple activities when you're working towards a common agenda. So yes, so the colleagues that I still am in contact with are very active in taking their agendas forward, and I often get notices of their activities, etc. All right. Well, colleagues, you have really touched us to the core of our essence of humanity, sharing with us your stories that are lived experiences. It's not like you're sitting somewhere and you're just air talking. You are sharing with us what you go through on a day-to-day basis. What are your challenges? And I know some of you have day jobs and you have to do this around everything else. So I really can't extend my appreciation for what you're doing in your country. And I wish you continued strength. And if ever you want some access to access the leadership of the academy in your country, please feel free to contact me at the Academy of Science of South Africa. I'd be happy to play the conduit in that respect and try to facilitate some aggregation of support for your initiatives. So thank you very, very much.
Thank you so much. And
We appreciate that.
And we just want to,
Yes?
we want the world to know what is going on now with the pandemic. This is what we're living with for all our lives. Oxygen, therapies, BiPAP. These are the types of life that we are facing.
Yes. And I would really encourage the three of you to get together and write a piece for the conversation. I think you have the merits of bringing your ideas together in a very strong position paper for the conversation, and that's distributed to millions of people. So please strongly consider that. Your stories are the ones that need to reach out to society at large. So that's where you should be doing it. And I really, really like the part where you say, what you go through on a day-to-day basis is what the rest of us are seeing through the disaster of the COVID pandemic. And yet, only now can we appreciate all the problems associated with rare diseases. So that is a striking note on which to pitch an article for the conversation. And I would strongly encourage that you do that.
Thank you.
Thank you.
Take care. Bye. Right.
Okay. Okay, great. So thank you very much, Prof. Himla, for facilitating the previous session. I think this was really fascinating. Very interesting to hear the voices of patients at this high level. And I also like the idea of us trying to make sure that at least we bring in the policy makers as well. I'm hoping that in future conferences, we'll have not just researchers and patients represented, but also to try and see how we are able to bring high-level policymakers to listen to these stories as well. And so I think this is something that I'll recommend for future conferences. We have our next presentation by Clarice Musana Baganwa. Sorry if I didn't pronounce it very well with my Ghanaian accent. But Clarice is a clinical epidemiologist and biotechnologist by training, and currently pursuing her PhD studies in epigenetics and bioinformatics with a research focus on epidemiology and omics of neuropsychiatric disorders, as well as other chronic diseases, primarily cancer and cardiovascular diseases, where she's leading different projects as a PI and reviewer of scientific journals. She's also occupying the position of medical research analyst at the Rwanda Biomedical Center since January 2021, where she was promoted to technically lead and coordinate the national medical research projects at national level. She has more than 10 years of experience in coordination and technical management of the health sector, research projects development, implementation at national and international level. And then besides, she also holds responsibilities of supporting the Ministry of Health in streamlining research regulatory frameworks that is conducive to medical research environments, as well as establishing strategies that attract international pharma and biotech industries to conduct clinical trials in Uganda. She was appointed as the national focal point of East African Health Research Commission activities and as the chair of the National District Research Challenge Fund. She's currently a member of the National Steering Committee in charge of National Health Research Agenda Development and Implementation. Such rich bio there. So Clarice will be talking to us, giving a presentation on trauma-related and neutral false memories and associated biological markers in patients with post-traumatic stress disorders following exposure to the 1994 genocide against the Tutsis. So Clarice, if you are ready, over to you.
18th H3 Africa conference. I'm Clarisse Msanabaganwa. I'm an epidemiologist and biotechnologist by training, and now pursuing my PhD in epigenetics and bioinformatics. In today's talk, I'll be discussing with you about trauma-related and neutral false memories and associated biological markers and intergenerational effects in PTSD patients following exposure to 1994 genocide against the Tutsi in Rwanda. This project is being implemented at the University of Rwanda in collaboration with Radboud University, University of South Florida, and Vrije University of Brussels. False memory is defined as a phenomenon where people recall things that were not presented to them or recall it differently from the way it happened. This Rodriguez-Delmont paradigm is one of the paradigms which is used in measuring the false memories. And this paradigm sees these false memories as source monitoring errors, which are produced when there is a presentation of series of words, which are semantically related to the real world, and then they conjure up in the mind of a participant. According to the scientists, false memories are part of the working memory and can be triggered from anxiety and stress. PTSD is considered as a disorder that also affects memory because people with that condition, they are troubled by recurrent intrusive distressive memories of traumatic events. Science has shown that there's an impact of associative activation mechanisms in the linkage between psychopathology and false memories. And mostly the false memories are produced when there is associative material which has been presented. So according to the researchers demonstrated that there is a link between war-induced PTSD and disorder. And also these dissociative symptoms are positively correlated with susceptibility to false memories on DRM task. PTSD group falsely recognized more critical role than other trauma-exposed participants with DRM task, according to the different scientists, but these discussions are under debate. Other scientists report that PTSD patients recall fewer words than participants without PTSD. Although several studies have been exploring the linkage between trauma-induced PTSD, there are many discrepancies between the findings on correct recalls of word and trauma-related cognitive tasks from DRM task. And there is no study which has been implemented in the context of Rwandan genocide with transgenerational effects on maternal stress. On the other side, at biological level, there are different biomarkers which have been reported to contribute in cellular stress response, such as HSP70, HSP90, and HSP27, cortisol, and others like glucocorticoid receptors. These biological markers have been reported really to be important in cell survivors And so we hope to study these biomarkers in our ongoing studies in the Rwandan genocide survivors population to understand the level of expression of these proteins in non-traumatized population and also traumatized population. So our hypothesis is that PTSD patients may have a particular impairment in source monitoring and towards tendency of higher production of false memories on DRM list in the context of genocide exposure. There are other different hypotheses being tested in this project, like as mentioned, level of expression of mineralocorticoids and the mentioned proteins, as well as glucocorticoid receptors. We assume that they differ between non-traumatized population versus traumatized exposed population and their offspring. We are also testing if there's a correlation between level of corticosteroid receptors and examined heat shock proteins, and this correlation may differ between the exposed group versus non-exposed group. We also want to test if there's association between DNA methylation and memory impairment, as well as intergenerational effects of PTSD and trauma among Rwandan genocide survivors. So our motivation here is that according to the global statistics, 70% of mental disorders contribute to global disability adjusted life years, which brings to the high level of burden of PTSD, like it is ranging at 3 to 4%, and depression at 4%. But when you look on the right side of this presentation, for Rwanda, the burden of PTSD is high among genocide survivors. It's at 28%, and depression is at 10%. So this really is motivating us to study more, to have more research questions in this population, so that we can build interventions to alleviate the burden in Rwandan population. So with this DRM paradigm, we want to use it in Rwandan context, and this may maybe decrease the discrepancies which are in available data on susceptibility to recall, critical rules, and trauma-related cognitive tasks. So the objectives is to examine the free recall and false memory rate among Rwandan genocide survivors, and to determine the association between trauma exposure and memory impairment. So as I mentioned, this is a piece of work which is linked with the ongoing project under NIH grant support and H3 Africa, which is looking at epigenetics and intergenerational effects in maternal stress, where we are determining DNA methylation status following exposure to 1994 genocide against the Tutsi, and also try to illustrate the intergenerational effects and epigenomic changes associated with PTSD and genocide. Methodology of this part, we are using DRM test, as I mentioned, and the DRM test is applied with the presentation of list of words that are associated with trauma, with also non-studied critical rules. The stimuli is 20 list of random words. Each list contains 10 words associated with one non-presented word. The 20 lists are divided in two sets, trauma-related words and neutrals. So the study design, it contains case and control groups. We will be having 150 PTSD cases, 150 resilient, and also 150 control group. Those who were not exposed to genocide, who were outside of Rwanda, women and their children during 1994. As I mentioned, the study tool is this Rodiga MC Dermot effect, and we generated our own trauma-related words and neutral words based on DRM lists which are available. So in our pilot phase, we did it on 36 participants, and we wanted to test the internal validity of the tools to be used. And these participants were students and staff members at the University of Rwanda. And then we added women and men at Kibagabaga Hospital who were chosen randomly. And this pilot has taken between 27 to 58 minutes. We did also pilot phase 2 to make sure that to test free recall and free recognition on generated disks. And this pilot was implemented at the same site, Kibagabaga Hospital in Bugesera. And a total of 50 participants were tested in 3 days. All participants were at AhESA Healing Center, and the time to complete the task was between 40 to 60 minutes per participant. So some of the findings that we've seen, we've seen that the list of words which were presented to the participants behaved to not be remembered easily and were not really associated between them. So here we are thinking that maybe culture and language are suspected to play a major role in DRM tasks within Rwandan context, but this needs to be confirmed at the larger population. The same with pilot 2, where we wanted to test the free recall and forced memory rate. We found that the free recall and forced memory rate was very low for all 20 disks which were tested. Only 2 words were forcibly recalled. And so it shows that the free recall was very low, and also the recognition was not well taken. On the average of these lists recalled, 4 words were remembered per list. So these are the findings of the pilot, and we are revising now the tools according to the findings from the pilot to really increase the validity of the tools that is going to be used on the larger population. So the next step is that we want to revise the tool by taking into consideration of those culture and linguistic factors. And also we anticipate to organize community engagement on memory quality study. And then we do data collection for the entire population for the 450 sample sets that we are anticipating to have by September to December 2021. So I acknowledge support for my supervisors, Professor Dion Mutesa, and Dr. Stefan from University of Rwanda, Professor Monica and Professor Derek from University of South Florida, Professor Beno and Professor Elno from Radboud University, and Professor Rose Gemini from Vrije University Brussels. Of course, we appreciate support from NIH and H3 Africa to be able to implement this kind of project. I thank you very much for your attention.
Yes, so thank you very much, Clarice. We don't have Clarice online, but we still have 15 minutes for this session. So I had actually suggested, I don't see any questions specific to this presentation, but I thought we could pick up, from the first presentation for this session, the presentation by Cynthia, but we're not able to cover almost all the questions that were in the Q&A. But maybe I would begin. Cynthia, I don't know if Cynthia, are you with us? Do we still have Cynthia with us? Okay, yes, great, Cynthia, yes. So I would like to ask to pick on some of the issues you raised in your presentation. One had to do with how we engage, especially local communities in setting priorities for research. As you know, in reality, in terms of how we set priorities for research, there seems to be more of a top-down approach. And so researchers go out, they identify a problem, they go out to seek funding, and then they engage with community members. In some cases, if you have local PIs who know the community very well, they are able to bring in that voice at that level. But how do we balance the idea of getting, driving research driven by community needs, which are not a priority for funders? Because sometimes when you engage with communities, they raise issues about, some of the issues that they are struggling with, but there's no funder who may be interested in funding such a project? How do we balance that to make sure that at least we have researchers, more or less addressing not so popular research topics that are still very relevant to communities? Your thoughts on this?
So that is a major problem. But we must also acknowledge that sometimes the researchers, especially those who are very involved in their communities, sometimes can speak for their communities, and most times their research is tailored to the needs of their communities, what they have observed and all of that. But things are gradually changing, and I think even the funders are beginning to be open to priorities that are driven by patients. And so, for example, we just heard Arafa talked about what is important to them. And that, for example, may not have been the things that Sickle in Africa set out to do at the beginning or was funded to do. But we have managed to sort of incorporate some of those things into the agenda. And I just put in the chat box a publication by Rafa and her colleagues on what they think could be the priorities, what are their expectations. And I think from that kind of advocacy, then funders, national governments can begin to pick, for example, what is of pressing needs to patients.
Yeah, great. Let me see if I have any more.
I was also going to say that the idea of writing for the conversation Africa is really great, because that is a medium that is read by many people, even outside research, and that's how you start informing policy. Yeah.
Paulina, can I ask a question, please?
Yes, please.
Yes. Cynthia, thank you very much for your rather engaging paper. It really covered, the space under which the other issues have come in. I would just like to pursue the issue or the point that you made about what does the public already know, and how do we fill the gap? Now, that is quite a poignant statement in the current context of us dealing, for example, with the COVID pandemic. And I am sure the Africa CDC and your internal layers of government have already made an impact in communicating information about the COVID pandemic and the SARS-CoV-2. But inevitably, social media has a way of driving the public view. How would you deal with a comparative of dealing with the disease studies like you've been involved with versus what you've been seeing in the public discourse with respect to what the public knows and how we champion giving them information to reassure them with any fears or misconceptions or myths or fake news? How would you deal with that?
I think my first approach is generally always acknowledging that the public knows so much. Because sometimes we assume that they may not know, but they do know quite a lot. And if we get into communities, just the know and sort of acknowledging where the mistakes are. I think for COVID, it has been more of a cancel culture than trying to listen to what they are saying and engaging them. So for most times on social media, even when it is misinformation, how do we respond to that? I think the nature with which we respond, those misconceptions or conspiracy theories, or it can just shut them up. So it is how we engage and going. Communities know better than us sometimes, and avoiding a cancel culture of saying just without giving really clear reasons for why that is not the case.
monitor social media, you would see more people from the general public comment on issues related to COVID. But when we talk about the diseases that we are interested in, we get very little soundbite from the public at large. Why do you think that's the case?
I think maybe it is how we write it. And sometimes who tells the story is as important as the story itself. So sometimes the story should not be coming from researchers. I think if I talk about sickle cell disease, I get less attention than if Arafa talks about it. And so people would engage with that much more differently. So who tells the story is important. I think sometimes researchers, the way we write for another audience. And sometimes we must also acknowledge that as academics, we come with some degree of power. You know, the society already sees you as up there in terms of knowledge. So what you say, it's a bit. But when it's coming from their own peers, then it becomes different. So who tells the story is important. And I really think that community engagement activities and those social media activities should be led by people in the community or by patients, depending on what the case is.
Julie Makani supports the idea about who tells the story is also very important. Paulina, I wonder whether you recall in the early days when I was part and parcel of the H3 Africa Ethics Working Group, I was punting for bringing in advocates to tell, you know, the message about what the whole H3 Africa program was about. And I said, you know, musicians, sports people, and the likes seem to have much better traction with the audience than we researchers do. And I was recommending that we reach out to these advocacy types people. But that idea has never really flown within the H3 Africa program. How would you see that, Paulina? I mean, you know, we're closing on to 10 years of the H3 Africa project. From your being there from the very beginning and co-chairing the ethics committee, etc., what are the win-wins in terms of our community engagement strategies that we can shout from rooftops and say, yes, we accomplish 1, 2, 3? What would those 3 things be from your perspective?
Okay, so I think we've come really far. I mean, since I'm an insider, I don't want to be seen to be promoting what we have done, but I think a lot is out there for people to read in terms of our experiences. In the first few years, I don't think community engagement was on top of the agenda. But over the years, we have seen community engagement being key. In fact, when you listen to all the presentations by all the projects, you hear something about community engagement, the processes that they are using, and all that. So we are beginning to see community engagement playing a key role in all the projects that have been carried out within the H3 Africa. And I think that we've also moved from just seeing community engagement as getting buy-in from the community, but also an opportunity for us to listen to what the concerns of the community is and how we can incorporate that into the scientific projects moving forward. I think that's the feedback that is also informing how we are looking at issues related to feedback or findings. Because those were some of the feedback we got from communities that, well, you are doing all this research, and so what? So what is in it for us? How are you using the data? What does the data look like? And what does it mean to us as individuals and as service data providers, as Cynthia put it? So now we are focusing more on how do we go back to communities and share not only the knowledge that we are gaining from genomics, but also begin to think about how we discuss issues related to benefit sharing. What are the expectations of communities, and how can we sort of work together to identify how to address these expectations? So I think that is how, in summary, I would put it. That at the beginning, not much, I don't think much was discussed around community engagement. Very few of us were actually having these conversations. But over the years, we've seen even projects, training, there are more opportunities for people to get trained in the ELSI, issues. We are seeing that a lot. And I think Cynthia is a great example, of how far we have come in terms of training people in this area and making sure that we address the issues that are raised at the community level. So this is what I would say in response. Yes.
Thanks. I don't see any other questions in the discussion forum. And if I could ask one more question to Cynthia, please. Is that okay? Cynthia, I'm always intrigued by the power of indigenous knowledge systems. When you are trying to engage at a community level, to what extent does that intersectionality of science, on the one hand, meet the indigenous knowledge system? And to what extent have your work or your ideas managed to mitigate between the two?
I think for me, that experience came more during the break. And because there was really sort of the community beliefs were very strong on how Ebola could be spread or the mitigation strategies that were in place. And in some ways, it influenced community engagement or public health activities. And I think for the Ebola outbreak, that was the case where we sort of really had to question the role of community engagement. And how community engagement sometimes, if it is not well structured, it could lead to a problem, because in terms of public health strategies like burials, the way we do burials, you know, and even around eating bushmeat and how it ended up around the transmission of Ebola. Bushmeat should not have been put up as a key, the eating of bushmeat should not have been put up as a key mitigation strategy on how indigenous knowledge should, in fact, in the first place, inform any community or public health engagement activity first before the science.
Thank you very much. I see our time's up, and I just want to say thank you to all the speakers and to Paulina for such an engaging discussion. I felt like a scientist again being part of this panel, and I have been enriched by the stories and your insights that you've shared. Thank you very much to one and all. Over to you, Paulina, for closing comments.
All right. So, we don't have enough time. So I'll just to add to say thank you very much to Cynthia, to all the presenters for such a very exciting session. And we look forward to continuing some of these discussions on another platform. And I wish you all the best and do stay safe. And bye for now.